Greetings and welcome to this new series of videos. In this series, we'll discuss about the lab investigations of commonly used tests like complete blood count, urine routine examination, renal function test, liver function test, and gradually we'll go and deep dive into the advanced tests that are used commonly in the physician practice. So in this module, we'll discuss completely in detail about urine routine examination. You don't need to watch any other video on urine routine examination in order to find the diagnosis with just a urine routine. So urine is almost equal to direct biopsy of nephron physiology. So that's what you're going to see in detail in this video. If you're new to this channel, do like and subscribe. This is Medicine Beyond Harrison's. Let's get started. So why urine protein examination is very powerful because it just reflects glomerular integrity and the tubular function very directly and detects interstitial inflammation as well as the systemic state also, and reflects the hemodynamic status and also localizes the pathology of where the pathology exactly is, whether it is in the glomerulus or in the tubules or in the collecting duct. It often localizes the pathology even before imaging or biopsy. So you have to consider few things before analyzing a urine protein. So you have to, in order to avoid misinterpretation and doing a microscopy, you have to know the key considerations. So sample type mainly the first morning sample, which is the best, and it is also the most concentrated sample. It is best used for microscopic examination. Random sample can be used for routine OPD screening, but not for analysis of microscopy. Catheter sample there can be traumatic RBCs, so avoid the interpretation of RBCs from a catheter sample. So midstream clean clutch reduces contamination and avoids abnormal presence of WBCs. So always ensure a midstream sediment evaluation in order to avoid vulval and peripheral squamous contamination, as well as first morning sample is best used for microscopy. These are the first consideration that you must need to know. And the timing of analysis, this is one most important thing that within 1 to 2 hours of sample collection, you have to analyze the urine routine, because delay leads to RBC lysis, gas dissolution, and bacterial overgrowth, and also alkalinization of the urine. And because pH shift will also happen when you hold the urine for more than 2 to 3 hours. So always analyze within 2 hours of collection of the urine routine sample. Storage, refrigeration actually induces formation of crystals like urates and phosphates which mask relevant sediments. So avoid refrigeration. Standing urine leads to increased pH due to urea splitting bacteria. So don't analyze urine beyond 2 hours. So all these considerations you must follow in order to avoid many diagnostic errors and also due to delayed processing. So you must understand all these things. Now let's get into the analysis part. So physical examination, observation itself is diagnostic in most aspects. Nowadays, most of the people are not getting and seeing into the color of what is the color of urine that the person is passing. So you must need to understand just a big based on when the patient is in the ward and on police catheter, looking at the urine bag gives a lot of information about the renal function of that patient. So when the patient is passing straw yellow color urine, which is normal, mechanisms based on the urochrome pigment. When it is dark yellow, it is concentration, might be due to dehydrated. Tea or cola colored urine is due to oxidized hemoglobin, suggestive of glomerulonephritis. Bright red urine or fresh blood, lower tract bleed. Brown urine, which suggests my presence of myoglobulin, it may suggest rhabdomyolysis. Milky lipid or chyle urine can be seen in nephrotic or filariasis. It can be frothy, also frothing. Green color from mainly due to drugs like propofol and amitriptyline. So you have to assess for the clarity when you see the urine sample. It should be clear, which is normal physiological state. If it is turbid, suggests presence of WBCs, pyuria, bacteria, or abundant crystals. So turbid urine suggests pyuria. Oily sheen, if the presence is oil and if there are few oily crystals there, it is classified for lipiduria in nephrotic syndrome or nephrotic range proteinuria. So order, so fruity order, you can always smell for the urine if the patient has passed urine recently in the blood or diaper. So it indicates fruity smell indicates ketosis, decay, or starvation. Ammoniacal smell indicates urinary tract infection with urease producing bacteria, for example, protease. So only if you know this stuff and how these smell accordingly, then you can identify and find the diagnosis for urine routine, urine order, and based on that you can diagnose few conditions. So chemical analysis, this is where the dipstick comes. So we'll understand the chemistry, just don't read science plus or minus. Not that, we'll understand why it happens in detail in order to understand the pathophysiology also. So first and foremost thing that you must need to look into the urine dipstick analysis or the urine routine analysis test is that the specific gravity. Specific gravity is mainly affected by glucose and proteins, may lead to false elevations. Osmolality is more accurate for tubular function. The normal specific gravity is 1.003 to 1.030. So may remember the number 3. It is either 1.03003 to 1.030. So when it is more than 1.020, suggest concentrated urine. If it is less than 1.010, it is dilute urine. Fixed when it is fixed at 1.010, it suggests isostenuria. That means the kidney is not able to concentrate the urine because of tubular failure or due to chronic kidney disease. Urine pH dynamics. So usually acidic urine is mildly acidic in nature. So acidic pH less than 5.5 suggests metabolic acidosis, high protein diet, and diabetic ketoacidosis. Alkaline pH of more than 7 indicates UTI with urease positive organisms or renal tubular acidosis. So persistent alkaline urine always suspect distal renal tubular acidosis, that is RTA type 1. So you must always remember when you look at a urine routine with an alkaline pH, you have to think of two things in mind. One is urinary tract infection with urease positive organisms or renal tubular acidosis type 1. So proteins, diptic discrimination detects albumin primarily. So it misses many light chains proteins and Benston's proteins and other types of proteins it fails to detect. It is sometimes false positive in alkaline urine also. These are the basic limitations of dipstick analysis for proteins. You can quantify this protein by based on the urine spot protein to creatinine ratio as well as the 24-hour urine protein concentration. Now, based on the urine protein creatinine ratio, which are widely available these days, 24-hour urine protein is not commonly used. Nephrotic range is more than 3.5 grams per day that we already know. So blood and peroxidase, if it is the blood is present, you must next see whether there is RBCs present or not. So blood can be seen in hematuria with intact RBCs, hemoglobinuria with just hemoglobin is there due to lysis of RBCs, and myoglobinuria in case of muscle damage. So all these three cases, blood will be positive, but in case of myoglobinuria or rhabdomyolysis, there will not be RBCs. So when the dipstick is positive for blood, but there are no RBCs on microscopy, that is suggestive of rhabdomyolysis. You need to remember this fact. You can diagnose rhabdomyolysis just by the urine routine analysis. Additional parameters that we can get from the urine routine is that the glucose, if it is positive, it suggests plasma glucose is more than 180, or you can be also seen in Fanconi syndrome. So when the renal tubular threshold for glucose reabsorption is 180. When the plasma glucose goes beyond 180 to 200, it gets reflected in the urine routine. So glucose is positive. Ketones can be present in DKA, starvation, isopropanol ingestion also. Nitrate suggests gram-negative bacteria in the urine, so needs a 4-hour dwell for that. So gram-positive, if the gram-positive bacteria is present, so it can be false negative. So it is not a perfect indicator for urinary tract infection anyway. So if it is positive, suggests gram-negative bacteria. Leukocyte esterase indicates pyuria. It can be false positive in vaginal contamination. So next coming to the urine microscopy, this is where you need to apply the core nephrology skill and the sediment examination. This is why DM level reasoning or the nephrologist level reasoning comes in hand. And if you master this skill, you can diagnose many other conditions that requires biopsy or an imaging. You can just directly diagnose with a urine microscopic analysis. First and foremost thing is the RBC morphology. So when you see a urine routine with blood present, and then look for RBCs in the urine. When the RBCs are present, then you must need to look for what is the shape of RBC in the urine, whether it is dysmorphic or it is isomorphic. If it is isomorphic, that it will suggest that it is beyond the glomerular basement membrane. Blood or RBC that passes through the glomerular basement membrane, when the basement membrane is damaged, will leads to rupture or change in shape of the RBCs. So that's why different RBCs are in different shape and becomes dysmorphic. Whereas RBC coming from the tubular structure are always isomorphic or uniform in shape. The next is acanthocytes that are lysed RBCs or bite cells or RBC that is damaged at some parts. These are present in more than 5% specific or glomerulonephritis, whereas in non-glomerular bleeds these are absent. RBC casts are present in glomerular bleed, whereas non-glomerular bleed, there is no RBC cast. So why can RBC cast form? RBCs are just coming out of the glomerular basement membrane with tubular proteins that are commonly present. It conjugates and forms your RBC casts. Whereas non-glomerular bleed, it arises beyond the tubules, so it will not be exposed to tubular proteins and doesn't form a cast. Glomerular bleed also accompanied by proteinuria, whereas non-glomerular bleed there is minimal proteinuria. The single flag will determine what is the site of the lesion, whether it is glomerular or non-glomerular. So white blood cells, it suggests pyuria. It suggests the presence of UTI, cystitis, interstitial nephritis, or pyelonephritis. The WBC cast is highly specific or upper tract inflammation or infection, either pyelonephritis or acute interstitial nephritis. Similar mechanism. When an WBC is present in the tubules, it gets combines with the tubular proteins like urochrome. It forms TAM phosphor proteins also. It forms WBC casts present in the urine routine. So it suggests it is highly specific for urinary tract inflammation, whether it can be pyelonephritis or acute interstitial nephritis also. So casts, so other types of casts that can be seen are hyaline cast. Hyaline cast are always normal, just formed by the urine. Tubular normal proteins like TAM phosphor protein can be seen in normally due to dehydration or due to strenuous exercise. So RBC cast we already seen it's due to glomerular nephritis, which is pathognomonic. WBC cast can be seen in pyelonephritis or acute interstitial nephritis. Granular cast, these casts when are specific casts due to acute tubular necrosis. When the tubules gets necrosed, more number of proteins are produced in the tubules, or the tubular epithelium also gets lysed and gets damaged and is found in the urine. These are granular in shape, also called muddy brown casts. So these are present in acute tubular necrosis. In fact, it is almost diagnostic of acute tubular necrosis with high confidence level. Fatty casts can be seen in nephrotic syndrome with lipid is just gets passed through the glomerular basement membrane, combines with the proteins in the tubules and forms casts. Broadcast can be seen in advanced CKD due to tubular dilatation. So the tubules get dilated. That is IFTA-GS, that interstitial fibrosis, tubular atrophy, and glomerular sclerosis is the pathognomonic feature, pathogenesis of CKD. In this, tubules get atrophied and gets dilated. Because of its dilatation, the casts that are normally formed are very broad in size. Because of the tubular dilatation, the space is more, becomes broad compared to the normal casts. So it suggests advanced CKD. So these are the common entities or the diagnosis that can be, you can suspect based on just the urine routine and microscopic analysis. Crystal geometry, so you can all there are a few crystals that can be found in the urine routine. Calcium oxalate crystals are usually envelope or dumbbell shaped. It is normal or due to ethylene glycol consumption. Uric acid crystals can be seen rhomboid crystals are diamond shaped, seen in gout or tumor lysis syndrome. Steroid crystals are coffin lid shaped, seen in Proteus uriae, and cystine crystals are hexagonal in shape, so also known as stop sign. This is seen in cystine urea. It's genetic condition. So these are the common crystals that you must need to remember in the urine routine analysis. So other microscopic findings are like epithelial cells. So when the squamous epithelial cells are present, it suggests contamination from the vaginal epithelium or the vulvar epithelium. So it suggests contamination. Renal tubular epithelium is a marker of acute tubular necrosis. So when you suspect the epithelial cells, you have to ascertain whether it is from the lower urinary tract like vagina or vulva, or whether it is from the renal tubular epithelium. Renal tubular epithelial cells are suggestive of acute tubular necrosis. Lipiduria, if present, this multi-sclerosis appearance in the polarized phase signifies nephrotic syndrome. So, other syndromic patterns of recognition. So, now we have gone into the details of urine routine examination and microscopic analysis. Now, we'll discuss about few pathological entities that we can diagnose based on the urine routine analysis. So, when you see a urine routine and when you see a acute kidney injury, think of these patterns during ward rounds in order to diagnose what is the pathology of this. Nephritic pattern. So nephritis, there will be tea-colored urine, dysmorphic RBCs or RBC casts. There will be mild to moderate proteinuria. The common causes could be IgA nephropathy, post-infectious glomerular nephritis, or lupus nephritis. All these are causes for nephritic syndromes. Other renal symptoms that can be, suspected based on the urine routine is that nephrotic, there will be heavy protein in the urine, lipiduria, fatty gas, and minimal blood. There will be zero or no blood in the urine, no RBCs. Acute tubular necrosis, in this case, we have already discussed, there will be muddy brown casts, renal tubular epithelial cells, and isocystinuria, that is fixed specific gravity. Acute interstitial nephritis, there will be WBCs present, WBC casts will be seen, and eosinophils are present in acute interstitial, interstitial nephritis. So, for in case of obstruction, there will be bland sediment, microscopic hematuria, and crystals will be present. So, mastering this nuance between albuminuria, sterile pyuria, and glomerular hematuria creates the advanced insights. This will get into details of much more details, and we'll know the advanced diagnostic skills based on the urine protein alone. So, renal diagnostic flow is that check for proteinuria. If it is present, then check for blood, then check for RBC shape, whether there is presence of casts or not, then assess specific gravity pattern, then correlate with the creatinine. So the urine plus creatinine plus clinical context always gives the diagnosis. So it will be just there in front of you even before a biopsy or an imaging. So what must be understood and perfected for a clinician is that the diagnostic skill always know to identify dysmorphic RBCs if you are doing a urine microscopic analysis, identify casts correctly, differentiate nephritic versus nephrotic appropriately, interpret protein semi-quantitatively, and you always do a urine spot protein to creatinine ratio or 24-hour urine protein analysis. Always correlate specific gravity with the tubular function. So more and more things when you start looking into urine protein, you will understand the nuances and you can identify the subtle crystals like sulfonamides or Indian avar crystals also. You can also recognize mixed patterns. Most of the cases there will be glomerular nephritis along with acute tubular necrosis also. So you can always detect early glomerular nephritis just based on the urine routine. The chronic or acute sediment detect distinction can be done based on the urine routine. So all these are advantages when you know the urine routine in perfection. So final insights, active sediment, if it is present, it suggests inflammation. Glomerular nephritis, there will be RBC casts and WBCs. In acute tubular necrosis, there will be granular casts. So bland sediment, if it is present, signifies structure and chronicity problem. So CKD, there will be broad casts and few cells. Nephrotic, there will be protein only. So there are few conditions that could be diagnosed with very much confidence based on the urine routine alone. With very high confidence, we can diagnose acute tubular necrosis, acute glomerular nephritis, nephrotic syndrome, rhabdomyolysis, and cystinuria with very high confidence. So whereas pyelonephritis, acute interstitial nephritis, and advanced CKD also can be diagnosed with high confidence limits in based on the urine routine analysis. Thus, all these things we have discussed in this module. That once you see this module in perfection and master this mechanism, you can diagnose the all these conditions with based on just the urine routine. So before ordering expensive tests and you go for an ultrasound imaging or biopsy, always ask: is the sediment active? Are casts present? Is the RBCs glomerular in origin or non-glomerular in origin? Is protein proportional or improportional? Always quantify the protein. Is specific gravity fixed or not? Or whether it is concentrated or less concentrated urine. So once you master these and ask these questions before going for further investigations, this will help you localize more than 70% of the pathology even before the renal biopsy. Yeah, this is what all about urine protein that we have got to offer. If you like this video, do like and subscribe and share it with your friends. This is Medicine Beyond Harrison's. We'll meet in yet another video in this lab investigation series. Thank you for watching.